Hello, dear friends. Greetings for the day. At the outset, I'd like to thank AORA India for this opportunity for presenting a webinar on assessment of left ventricular systolic function as a POCUS modality. I bring greetings from Asian Institute of Medical Sciences, which is a 425-bedded multi-specialty and super specialty hospital situated in Faridabad, the heart of Delhi NCR. Apart from our clinical routine work, we do a lot of academic work in the form of DNB, and we do have a research fellowship program in regional anesthesia accredited by Academy of Regional Anesthesia. So if you're interested, you can get in touch with me. For this set of lecture, I do not have any conflict of interest, and you will see some images from Google. References are from PubMed. And in my presentation, you will find a couple of QR codes which will directly take you to the landmark articles. So this is how I have planned my lecture. We'll try to understand what actually is LV function, why is it important to the anesthesiologist, what are the various assessment methods which are available in the armamentarium as a POCUS modality, and in the end, we'll like to summarize our findings. So this is the basic I-AIM framework which is used to describe any POCUS modality. It's an acronym which was given by David Banner and colleagues as early as 2012. And whatever POCUS modality we are trying to understand, this holds true. I stands for indication as to why we are doing that POCUS examination. A stands for acquisition of the image and further optimization using the parts maneuver. I stands for interpretation of that image, and M stands for medical decision making as to how that POCUS modality helps in taking decisions. Let's begin with introducing the subject as to the importance of LV function assessment. We know that LV function is a crucial indicator of overall cardiac health. The assessment helps in the diagnosis, the prognosis, and the management of various cardiovascular diseases. It also guides treatment decisions, including medical therapy, interventions, and for device implantation. And we all know that LV dysfunction is a major cause of heart failure. And if we actually look closely at it, left ventricle ejection fraction is the most common marker which is used to assess the LV function. And ejection fraction, as we know, is a percentage of blood which is pumped by the left ventricle with each contraction. And it is given by the formula of stroke volume divided by end diastolic volume multiplied by 100, and it is reflected in percentage. So my dear friends, what are the indications of LV function assessment in the perioperative period? We can have an individual who's having a chest pain, which is not overt and has come to us for a surgery. At times, cardiology evaluation is not possible. In such cases, we can consider this modality. At times, patients have dyspnea, which they have been ignoring for a good number of times, and whenever they land up for surgery, they can have implications in the perioperative management, and these are the cases which we like to evaluate. And when we are working in ICU or ER, we have crashing patients. Immediately keeping a echo probe on the chest of the patient would answer so many questions. And definitely, unexplained hypotension in the perioperative or the postoperative period is a good indication for doing a fate examination and assessment of left ventricle. Before actually embarking onto the POCUS examination of doing a fate examination and assessment of left ventricle, it is prudent that we follow the basic steps. That is, first we look into the history, then we do a good thorough physical examination, and then pick up the cardiac echo probe. History, particularly symptoms such as dyspnea, fatigability, edema, and hypertension and diabetes are the risk factors. Physical examination, particularly, we look at JVP, heart sounds, whether the individual has peripheral edema or pulmonary rales. So, if we look at it, our cardiologist friends use various tools to assess the left ventricular ejection fraction. Some of them are the eyeballing technique, the Simpson's method, which is considered to be the gold standard method as per American Society of Echocardiography for finding out the ejection fraction of the left ventricle, wall motion score index, fractional shortening, AV plane displacement. But as anesthesiologists, we are not supposed to know all of these methods. I was speaking to a cardiologist friend of mine, and they told me that eyeballing technique is the method which they use most commonly during day to day practice. And this is the one which, as anesthesiologists, for doing a POCUS examination for assessment of LV, we are going to use the same. We have to understand one important thing, that we are not here to replace the cardiologist. It is quite possible at times they are busy in the cath lab, or it's in the middle of the night. We are finding a cardiologist is little difficult, and we are having a laparotomy where we need to understand the left ventricle function. Then we have to understand that it's essentially a goal directed examination, and it's problem oriented. Is the patient having normal ejection fraction? Is the patient having a valvular heart disease? And it's limited in scope. We are not going to replace our cardiologist friends. We are doing a focused cardiac ultrasound examination as a part of point of care ultrasound examination. So, how do we actually assess left ventricle? There are two important methodologies. One is the qualitative assessment, another is a quantitative assessment. In subsequent slides, step by step, I'll take you through the qualitative as well as quantitative methods of assessment of left ventricular ejection fraction. So, which views should be used for qualitative assessment? As per FATE focus assess transthoracic echocardiography, all the four important views, particularly the parasternal long axis, parasternal short axis, apical four chamber, and subcostal four chamber views are used for qualitative assessment. But if you ask me, out of these four, which are the two most important for qualitative assessment, then the answer would be parasternal long axis and short axis. Before actually delving into these two views, just we like to recap what we know from the FATE examination. These are the basic FATE views. The subcostal four chamber, which is the position 1. As you can see for yourself, the orientation marker is towards the patient left, and cock to grip is used, and we try to look at all the four chambers. Then position 2 is the apical four chamber. Again, we are trying to place the probe at the apical pulse, that is the mid-clavicular line, fifth intercostal space on the left side, and the orientation marker is marking towards left. Parasternal long axis view in FATE views is the only view where the orientation marker of the phased array cardiac probe points towards the right shoulder. Otherwise, if you have a close look at all the views, the probe orientation marker is pointing from the left elbow till left shoulder. For example, for parasternal short axis, that is the position 3. This is the basic premise of assessment of LV functions, that we need to be proficient enough to have a good FATE views. So as I said earlier, we can use all the four views for assessment of the left ventricle in terms of qualitative assessment, but parasternal long axis and short axis views are the most important. Let's have a look. So the technique which is used by the cardiologist is eyeballing technique, and the similar technique we'll be using for doing our qualitative assessment of left ventricle function. So how do we actually assess whether my LV is normal and term it as a normal ejection fraction? So first and foremost is, in parasternal long axis view, we have to observe the movement of endocardium towards the left ventricle cavity. Next step is, as our peripheral muscles, like if I contract my muscle, it gets thickened. Similarly, during contractions, thing labeled as number two is the myocardium. It actually thickens. Last but not the least is the anterior mitral leaflet movement towards the interventricular septum. If it moves and touches the interventricular septum, then the ejection fraction by eyeballing technique we can term is normal. So what is the interpretation we can draw from qualitative assessment? One, a heart could have a normal ejection fraction, or it could be a hyperdynamic heart, or there could be some LV dysfunction which can be categorized as mild to moderate or severe. Let's have a look at the videos of a normal LV function in parasternal long axis view. As you can see for yourself, the endocardium is moving towards the cavity. The myocardium is thickening. The anterior mitral leaflet is moving towards the septum. So this can be termed as normal LV function because the anterior mitral leaflet moves and touches the interventricular septum completely. Now, how these findings appear in parasternal short axis? Again, we can observe the entire left ventricular endocardium is squeezing with the contraction and moving towards the center of the cavity. Also, there is a thickening of the myocardium. So these findings suggest that the LV function is normal. What about a hyperdynamic heart? The one which is beating much faster. As you can see for yourself, there is an increased endocardial excursion. There is a near total obliteration of the LV cavity in this still image. And in the plaques view video, you can see for yourself that the entire cavity is almost obliterated. In the short axis view, you can see there is a tachycardia. The entire valves are contracting towards the center and there is a near total obliteration. So this reflects a hyperdynamic heart in various views. What about reduced LV function? It can be mild to moderate or severe. And the principal features would be decreased endocardial excursion, decreased myocardial thickening, and reduced excursion of anterior mitral leaflet towards the interventricular septum. The left hand side of the image, which is labeled as mild to moderate LV dysfunction, you can see for yourself that the squeeze is not that good. Endocardium is not well moving towards the center of the cavity. The myocardial thickening has decreased. The anterior mitral leaflet is not touching the interventricular septum. The right side of the image, it's a form of extreme, that is the severe LV dysfunction. The anterior mitral leaflet is hardly moving towards the interventricular septum. So these findings reflect that the patient is having mild to moderate or severe LV dysfunction on the basis of eyeball effect. Up till now, my dear friends, we have studied the qualitative assessment with the help of eyeball function. Now, can we assess left ventricle in form of quantitative? The answer is big yes. In order to do a quantitative assessment, again, two important views would be parasternal long axis and apical fortune. In parasternal long axis view, we can perform two important calculations. One is known as EPSS and another is known as fractional shortening. EPSS stands for end point septal separation, which actually measures the distance traveled by the anterior mitral leaflet towards the interventricular septum. Fractional shortening is another modality which is used to assess the LV quantitatively in parasternal long axis view. In apical four chamber view, once we get a good view, we can perform the examination known as MAPSI, which is an acronym which stands for mitral annular plane systolic excursion, which measures the excursion of the mitral annulus towards the LV apex. So in subsequent slides, I'll tell you how to assess these quantitative parameters. Let's first understand endpoint septal separation. In order to get measure endpoint septal separation, we need to get a good parasternal long axis view. Then we make the use of M mode cursor as it can be seen in this ultrasound image. M mode cursor is placed at the tip of the anterior mitral leaflet. Once it's rightly placed, we obtain a M mode trace, and in M mode trace, we have to identify following features. First, the right ventricle, the interventricular septum, the LV cavity, which appears black or anechoic, and the anterior mitral leaflet movement is reflected by the E wave towards the interventricular septum. Once we get a good satisfactory trace, we freeze the button and then press the calculation button on the sonocyte machine. Then we can measure the distance between the E wave as well as the interventricular septum. And the machine does the auto calculation and it reflects the endpoint septal separation as 0.57 centimeter. So my dear friends, the next question comes, what is the normal value? Anything less than 7 millimeters is termed as normal. If the endpoint septal separation is between 7 to 12 millimeters, it means it is mild LV dysfunction. If it is between 13 to 24 millimeters, it means it's moderate LV dysfunction. And if it's more than 24 millimeters, it reflects as severe LV dysfunction. So in terms of EF, greater than 55 is considered to be normal. 45 to 54 is mild. 30 to 44 is moderate. And less than 30 is severe. So this is the video of a real-time measurement of the endpoint septal separation, where the M mode is placed at the tip of the anterior mitral leaflet, and we get a good trace, and then we freeze the screen and perform the measurements and get the values of endpoint septal separation. Now coming on to another modality which is used to estimate the ejection fraction quantitatively is the fractional shortening. This also is used by cardiologists, and if you have gone through the echo reports by cardiologists in detail, they refer to as EF as well as fractional shortening. So how do we get fractional shortening? In order to measure this value, we need to have a good parasternal long axis view. Now, instead, the M mode cursor being placed at the tip of AML for measuring EPSS, we place the M mode cursor in the mid LV cavity. We press the M mode trace. Once a satisfactory trace is obtained, we press the freeze button. And then we have to use this formula where we have to measure the left ventricle and diastolic diameter, which is the maximum diameter reflected as A in this ultrasound image. And we have to also measure the left ventricle and systolic diameter, which is the smallest diameter as reflected by B in this image. And the machine has got AI features. It can do a auto calculation with sonocyte machine and give us the value of the fractional shortening by using this formula, which is diameter during diastole minus the diameter during systole divided by the diameter during diastole into 100. So what is the relationship between EF and fraction starting? Fraction starting and EF are approximately related by the multiple of 2. So if it's greater than 25%, it's normal. Between 20 to 25%, 20 to 24% of fraction shortening is considered mild LV dysfunction, where you can compare it with EF. Moderate is between 15 to 19, and severe is less than 15%. So this is how we actually do the measurement of fractional shortening. As you can see for yourself, the M mode cursor is placed in the middle of the LV cavity. And once we get a satisfactory M mode trace, we'll press the freeze button, use the calculation button in the sonocyte machine, and it will auto calculate for us the fractional shortening once we measure the maximum diameter, which is reflected as the diastolic diameter, and the minimum diameter, which is reflected as the systolic diameter. Now, coming on to another important parameter, which is termed as the mitral annular plane systolic excursion, which measures the excursion of the mitral annulus towards the apex of LV, and it's a surrogate measure of the left ventricular ejection fraction. So it is obtained in apical four-chamber view. So we have to avoid foreshortening and ensure we have a good apical four-chamber view on our screen. Again, we'll make use of M mode cursor. Now the M mode cursor would be placed at the lateral mitral annulus, which I'll be showing you in the subsequent slides. We'll activate the trace, and once we get a good trace, we'll freeze that. We'll calculate the distance which the mitral annulus has traveled towards the apex. And in males, greater than 13 millimeter is considered normal MAPC values. In females, greater than 11 is considered as normal. So what are the normal values, my dear friends? It's greater than 11. And if patient has got 9 to 10 millimeters of MAPC, it is considered as mild LV dysfunction. Between 6 to 8 is considered as moderate, and less than 6, whether in males or females, is considered as severe LV dysfunction. So how do we actually measure? This is the apical four-chamber view. I have placed my M mode cursor at the lateral mitral annulus. It can alternatively be done at the septal annulus. Some people suggest take both the values and divide by 2, but alternatively, a single value can hold true. And once we are sure, then we can have a good mode trace and then use the calculation button. At the bottom, you are seeing TAPC instead of MAPC. I have done the values measurement as MAPC, but Sonosite machine in Edge model does not give a separate tool to measure MAPC, but it doesn't make any difference whether we measure MAPC or TAPC. We know that we have placed our M mode cursor at the mitral annulus. Had I placed my cursor at the tricuspid annulus, then this TAPC would have reflected the true TAPC. But since I have placed this M mode cursor at the lateral mitral annulus, I know this is reflecting as MAPC, and this is absolutely normal. Now, my dear friends, I have discussed the qualitative as well as quantitative assessment of left ventricular ejection. The next question comes to the mind is, we are not cardiologists, we are perioperative physicians, that is anesthetists. So whatever methods I have enumerated, is there any evidence to state that these hold good and measure the LV function accurately? Let's go through the evidence. Is eyeballing technique accurate? Yes, my dear friends, it functions almost equivalent to a Simpson's method, which is the gold standard for measuring LV injection fraction as per American Society of Echocardiography. Does EPSS and MAPC tell us the correct ejection fraction? My dear friends, these three references I would request that you take a screenshot, and these are the QR codes. You scan them. These will directly take you to these articles where you can see for yourself that whether you use eyeball technique, EPSS, MAPC, all of them are going to tell you the correct ejection fraction, provided you have performed the examination in the right way and you know the shortcomings of these examinations. So now coming on to the pitfalls or the shortcomings of using these focus modality for assessment of left ventricle ejection fraction. As I said, the basic premise is that you have to have a good understanding of the basic field views. You should be knowing which is the best view. If you are having a off-axis image in the parasternal long axis, you'll overestimate the LV systolic function. So again, one thing comes that you have to have a good knowledge and you have to have a good hand to get a good parasternal long axis view. Similarly, if in the apical force chamber view, as I said, if there is a foreshortening of the LV apex, then you will get an overestimation of the LV systolic function. How can we get underestimation of the LV systolic function? If there are any regional wall motion abnormalities, if there is an aortic insufficiency or mitral stenosis in parasternal long axis view. And similarly for apical four chamber view, if there are regional wall motion abnormalities, then you might not get the exact values. So what are the clinical applications? Preoperative risk satisfaction is very important in case of a cardiac patient scheduled for a non-cardiac surgery. At times, cardiologists may not be available. In order to avoid wastage of time, we as perioperative physicians can step in and use this focus modality for assessment of left ventricle. We can monitor the response to therapy. We have given some decongestant. We have to monitor whether there is improvement in LV or not. We can guide the hemodynamic management in a critically ill patient, and we can have prognostic implications of LV dysfunction. So, my dear friends, the next question comes to our mind. Can I do the LV assessment by just listening to one lecture? The answer is big no. This lecture is just the basic, and you have to build up your practice on this because what your mind doesn't know, you will not be able to see. So my request is first understand how to get good page views, then understand the importance of assessment of LV function and how many scans are needed to gain proficiency. This is from the Regional Anesthesia Pain Medicine article. If you scan this QR code, and I would request certainly to scan it and go through this article, they have divided the studies into two sets for all focus modalities. One is the level 1 study, another is a level 2 study. The question comes, what is the level 1 study? Level 1 study is the supervised study which are personally performed and interpreted under the supervision of an expert. In level 2 study, you are not performing the test yourself, but you are being supervised. And if you have a close look, for cardiac, it is the maximum. You need 50 level 1 studies and 100 level 2 studies, making it total to 150 studies. Whereas other modalities, for example, airway, lung, EFAST, gastric, it's 30 plus 20. So thereby telling us that cardiac focus is the most difficult out of all these focus modalities. My dear friends, this brings me to the tail end of my presentation. The take home message is that left ventricle function assessment is essential for cardiovascular care. And on the basis of qualitative and quantitative assessment, you can categorize the EF as normal, mild, moderate, and severe LV dysfunction. Echocardiography is the primary imaging modality. Once you have taken a good history and performed a physical examination, then pick up the probe. And clinical context is important when interpreting the results. Thank you very much for patient listening.